pain, flat foot are all similar conditions which start as a functional problem, and if not treated appropriately with the causal condition, can further lead to osteoarthritis or a patellocondral damage, or you can have a rotator cuff tear, and so on and so forth. So eventually they will overlap, but it's very important to pick the condition when it's in the functional stage, so that the therapist can restore anatomy and restore that biomechanically neutral joint as soon as possible. Now, coming to a little bit specifics, the supraspinatus gives us a lot of grief. The only muscle that gives me more grief and our therapist is the infraspinatus more than the supraspinatus. We were a lot of myths about supraspinatus. We were told it's the first gear, it kicks in first, and then the deltoid takes over. There's nothing like that. The supraspinatus is active during the entire arc of abduction. The supraspinatus is the workhorse of the shoulder. So what it does, like most of us understand, is that it provides concavity compression along with the other cuff muscles. So it's not working alone. The supra, subscap, infra, to some extent teres minor, are collectively stabilizing the head of humerus into the center of the glenoid, creating a fulcrum so that the deltoid, which is the powerhouse, can start functioning into abduction. And that's why the EMGs in deltoid kick in later after the supraspinatus has kicked in. So overuse is one of the commonest causes of degeneration, because that has been proven that chronic overuse will create collagen damage, collagen alignment, collagen disruption, leading to infarction of the tendon, leading to an eventual tear. So when a patient tells me that he got off from the bed and put his hand down to lift his body up, and that's when he couldn't lift his arm up, and then he was found to have a rotator cuff tear, it is imprudent to think that getting up from the bed put so much pressure that the rotator cuff tore. Often it's a trivial trauma where they fall in the bathroom, and they probably fall in the bathroom a dozen times. And then suddenly 10 years later, she falls again in the bathroom, and you say it happened because of falling. It was waiting to happen. So the overuse had led to a lot of collagen damage over time. And that's why very often you will see a patient with 3 weeks history of trivial fall, and when he brings in his MRI, there's like a whopping big 35 mm tear. So that 35 mm tear hasn't happened in 3 weeks time. It's inconceivable. It can. It's been waiting to happen and progressively gets better. And important for us to realize that this is a culmination of a lot of disease and degeneration over the ages. The supraspinatus alone is not the only abductor. The subscap, by virtue of its schizophrenic nature, can provide abduction. The subscap infra together can provide abduction, and the deltoid itself can provide abduction. It's rather inefficient in the absence of the supraspinatus. But some of us have that magic. We are biomechanical artists, so we are able to generate those force couples to substitute the supraspinatus finally. And that's why in the absence of supraspinatus, even in the presence of a tear, we still have good function. Coming to infraspinatus is most commonly weak collectively amongst the patients. Often there's a wasting. The insertion of the infraspinatus is far anterior, and by virtue of that insertion, where it crosses the supraspinatus and inserts laterally and not only posteriorly, is very interesting because it gives it additional capacity to do more than external rotation. In combination with the teres minor, it can provide 80% of the external rotation power in the shoulder. And so all the other muscles are contributing very little. Now, this is a very important ratio that we need to use when I talk about force couples. When you look at subscap, it is 1/5 the internal rotation power, because there are huge 5 large internal rotators that can substitute the subscap. Whereas on external rotation, it is infra with teres minor. And if you have a tear of infraspinatus or you have a neuropathy of teres minor, it can lead to a disaster because they are the main workhorses for external rotation. When there's a suprascapular neuropathy, or rather if there's a suprascapular neuropathy, it could be subtle, mild neuropraxia. The first muscle that we affected is the infraspinatus. So whenever you see rapid wasting, whenever you see a lot of fatty infiltration on the MRI, whenever you have a younger patient and you have a weak external rotation power, do be sure that you've not missed neuropathy, because it's very easy to miss it because it is a purely motor nerve. If you check The sensory nerves that get damaged are very easily picked up, but motor neuropathy is very rarely picked up on nerves which are pure motor nerves. So we're talking about long thoracic nerve, we're talking about accessory nerve, we're talking about the suprascapular nerve, and that's why they need a lot of high level of threshold of attention to be able to diagnose suprascapular neuropathy. Subscap is peculiar. I call it schizophrenic because there's an upper subscap, there's a lower subscap. Although they are connected, they behave differently and have been evaluated differently. The EMGs are said to be different for the lower subscap and upper subscap. The tests are different for the upper and lower subscap. It's one of the 5 internal rotators. So an isolated subscap tear often may not present itself. Patients are innocent. They will continue using their arm in internal rotation. I'll maintain that I have a strong internal rotation. The biceps will be painful, and that's how they will present to you. But as a corollary to this, although an isolated subscap tear can be hidden and not manifest early, if you have a supraspinatus tear along with a subscap tear, they will deteriorate very quickly. On the other hand, all the procedures that are used to substitute a massive supraspinatus tear, like a lat dorsai transfer, like a superior capsule reconstruction, like a lower trapezius transfer, will fail if there is no subscap there. So subscap is a very critical column that supports the shoulder, and it's a very crucial force couple along with the infraspinatus that is mandatory to allow the shoulder to function correctly. So I offer a great deal of respect to the subscapularis, and very important to address it. There's a very interesting thought about subscap of should we strengthen it or not to strengthen it. I shall discuss this at the end of my talk if I remember that. So not only is the subscap provider of power, not only is the subscap a major internal rotator, but as the arm goes into abduction, the subscap goes above the equator and can behave like an abductor or pull the shoulder down as well. So it can be a potential abductor once the arm reaches a certain level because of the way it is approaching. Now, coming to this golf ball, the shoulder joint is glenohumeral joint is exactly like the golf ball configuration. The glenoid, which is the T of the golf ball, is very tiny. Proportionally, I can tell you on an average glenoid AP diameter is about 25 mm. Sometimes in Indian ladies, even lower, and the head of humerus is almost on an average 50 mm. So it's double the size. It's very unstable. It's designed in such a manner that it offers us massive mobility. As Ram alluded, that we can get a 180 degrees. No other joint can offer that. But that stability comes at the cost of stability. So the mobility comes at the cost of stability. And that's why we have so frequent problems with the shoulder joint. And it requires a lot of biomechanically active muscle, ligaments, and structures to keep that joint stable. That's all. So the two of the most important force couples are the supraspinatus and deltoid, which have to be in conjunction to ensure that the head of humerus does not proximal migrate. At the same time, the internal rotators, so let's say subscap, and the external rotators, let's say infraspinatus, together have to contribute equally to keep that head centered in the glenohumeral joint. Now, this is what I meant by COR. The center of rotation has to be in a very small line within the center of the glenoid. As it starts moving on the sides, either anterior or posterior, it will wreak havoc on the shoulder biomechanics, and the cuff muscles will not be able to provide their critical function of concavity compression. And that's why when you say that an infraspinatus is weak, you look at it as an isolated weakness. And we tend to address shoulder problems as a homogeneous problem related to one muscle. And so I often get asked the question, so which muscle should I strengthen if I have this problem? That's not it. The answer often, as in life, is there's a mix of heterogeneous issues there. When that infra is weak, the subscap remains strong. As it is, the subscap is 20% stronger than the infra. So that center of rotation is going to move forwards anteriorly away from the center of rotation and slowly start articulating with the anterior glenoid and will disenfranchise all the other external rotators and create problems. And that's why patient will perceive this as a poor posture, inability to lift the arm up, or anterior impingement. Coming to instability, the reason the term from recurrent dislocation has changed to recurrent instability is even small episodes of subluxation are as sinister as that one episode of dislocation. So do not neglect that patient who says that he has multiple episodes of instability which are small and I can put the shoulder back in. It's happening, it's as bad as dislocation. So that's why. Now, again here, you have to discriminate between functional and structural. So if you have a labrum tear, if you have anterior glenoid loss, I can understand this is a surgical problem and that has to be restored surgically in more often than not. But there are enough patients who have a mismatch in functional performance, such as the infra is terribly weak, the subscap is pulling the head out, and so that mismatch, if corrected, can restore the instability in a patient without a structural problem. A scapular dyskinesia, winging of scapula, will tilt the scapula anteriorly, open out the joint anteriorly, and create the head to slide anteriorly. And once that anteversion has been created, it's very easy for the patient to sublux easily, in spite of having a normal labrum and an intact subscapulary. So it's very important for the clinician on the therapist side and the surgeon side to understand altered biomechanics and a structural tear. So herein, the very important statement from Vladimir Janda was that you have a functional problem, don't dig for an MRI to address your functional problem. Your MRI is going to come out normal. Just because somebody's MRI is normal does not mean that they don't have a problem. Imagine somebody has an imbalance between their force couples of external rotation versus internal rotation and is subluxating, and you do an MRI and turns out normal and tell the patient normal, go home, there's nothing you can do about it. So that's important. Again, if you have a minor first time labrum tear, it's still possible to rehabilitate them to their normalcy until unless they develop a bony Bankart or an anterior glenoid bone loss, when they have shifted into the structural deficiency where they're likely to need a surgical resolution. Coming to a little bit of nitty-gritty here about biomechanics, I would like to explain neighborhood syndrome. I need your attention here. This is not given in the books. This is what we follow. The long head of biceps is a notorious tendon, and a lot of patients have biceps problem, and we tend to address it as a homogeneous biceps problem. But you look here on the right bottom side here, the biceps is lurking right near where the subscapula is inserted. And if you look here, this is where the anterior supraspinatus inserts. Both of them contribute fibers to the pulley around the biceps. Now imagine a situation where there's a subscap partial tear involving the pulley as well. The long head of bicep is going to start flapping in the wind. You do a sonography and MRI, everything is normal. And the patient keeps telling you that I have pain in this line here in the biceps. How is that influenced? You will have to imagine in a 3D manner and understand that over that area is the anterior acromion. So somebody has a poor posture and has a reduced acromiofemoral interval. Every time they go into 90 degrees flexion and above, they're going to pinch that biceps. But it will never be accurately biceps, depending on that patient's profession. If you were a istriwala or somebody who's ironing clothes all the time, he's doing everything in internal rotation, which means he's drawing the anterior supraspinatus and the biceps underneath the anterior acromion and damaging it by repetitive microscopic damage. And that's leading to a tear. What does the patient complain? He doesn't complain of cuff tear. He complains of bicep pathology. Look in its neighborhood. The biceps is waking you up, giving you a sign that there's something happening in my neighborhood. That is very important. Similarly, the subscap tears. Subscap tears are known to be innocent. Patients they don't realize the loss of power, but the subscap and long head of biceps are fairly amoral, both of them. Whenever a subscap tears, the long head of biceps elopes with the subscap. And so if you see a dislocated long head of biceps, don't get excited. That is probably a sign of a subscap tear. Point I'm trying to make here is whenever you get a biceps tear, look in its neighborhood for the root causal etiology. It is very commonly anterior acromion. very commonly anterior supraspinatus or a subscap superior half problem, and then address that problem that will resolve the biceps issue rather than inject the biceps. A poor posture can bring that accruement down and create that impingement anteriorly. And that's why you must understand the neighborhood concept on these patients. Again, beg your attention for 2 minutes, where I'm going to try and explain the concept of internal impingement. For those who are unaware, internal impingement is where the posterior glenoid will rub along with the posterior superior cuff and cause it to fray during extreme abduction movements, typically seen in an athlete. But I'm trying to explain you the genesis of the slap tear or internal impingement. Both are very common terms. They are one leading to the other. So that's why I'm addressing both together. And if you understand the whole process and genesis of this, then the therapist understands what to treat rather than treat it as an MRI finding, this is internal impingement or this is slap tear. So look at a throwing athlete who's involved in repetitive throwing, and often he exceeds himself and he starts throwing 1,000 balls every day. And the structure that prevents instability in this repetitive throwing movement are the anterior inferior structures, such as the subscap and the anterior inferior capsule with the IGHL. Now, what happens here is because of overuse and repetitive throwing, it is important to understand that the structure that is likely to fail first is the subscap because it's a muscle prone to fatigue. Before I continue with this, I must explain to you that constant contact between the posterior glenoid and cuff is very common in an athlete, very common in an overhead athlete. But there is also an associated posterior subluxation or posterior offset, or posterior translation is a better word, which obviates the impingement. So that's why there is no damage to the cuff. So two aspects are protective for slap tears or internal impingement. One is the posterior translation of the head of humerus over the glenoid during wide abduction, and retroversion or retrotorsion. Now let's come back to our problem. That overuse led to a subscap fatigue. Because of the subscap fatigue, the player continued to play in spite of the subscap fatigue. He didn't realize that. And then the entire pressure was borne by the anterior inferior capsule and IGHL. So being a plastic structure, it undergoes plastic deformation and then it starts stretching out. So now you have a situation which is a single whammy where you've got weak subscap and you have got a lax anterior IGHL. So what has happened now is the head of humerus has started moving anteriorly from the center of rotation. Now this has negated that posterior translation, and that's why it has started encouraging the first contact between the posterior glenoid, posterior superior glenoid, and the rotator cuff. Whilst this is happening, if the head moves continuously in anteriorly, what happens is because of the lack of posterior translation, the posterior capsule or the infraspinatus, one of the two, can get tight. When the posterior capsule or the infraspinatus get tight, you've got a double whammy now, and that is that you've got anterior laxity and you've got posterior tightness, and there is no question of translation, but in fact there's tightness. This is where internal impingement begins. And when internal impingement begins and the player continues to play and throw, they lose their internal rotation in that position. This is the beginning of GERD. And once that happens and he continues to play again, is the third thing that happens. And the triple whammy is when the posterior cuff starts getting damaged because it's nipped between the head of humerus and the posterior superior glenoid. So now you have a partial tear of the rotator cuff, you have a tight posterior capsule, and you have a lax anterior soft tissue envelope. This triple whammy is the first remark that there is a slap tear in the making. And so if a smart therapist, if you can pick up this patient between this stage, then they can, number one, start stretching the posterior capsule. You have no leverage on the anterior inferior lax capsule, but you can strengthen the subscapularis and restore the biomechanics, correct the scapular dyskinesia, and then you can restore this patient normal if the sleeper stretches to stretch out the posterior capsule. So here posterior capsule stretches is well understood for GERD. What is not well understood is the subscap strengthening. So There are only few conditions where you would proactively do a subscap strengthening on an already strong muscle. One of them is the slap. And this tells you the genesis of the internal impingement and the development of slap. And herein, you can then use this information, apply it, and by application of this biomechanics, you will prevent the slap. For my clinician friends, a slap tear is not a diagnosis in MRI, which can be commonly a false positive report. I must have a throwing injury of significance. I must have a GERD. I must have a sick scapula. I must have a weak subscap and weak infraspinatus or a tight infraspinatus. I must have O'Brien positive without labrum tear. I must have a crank and Job's test where I'm doing this and there's a tightness or pinching behind, not an apprehension. And then perhaps if the MRI is positive, I would regard this as a slap tear. If any of these are negative, even a single point, I will not treat this as a slap tear and we will continue to treat it as an internal impingement. So there's a very fine gray zone between internal impingement and a slap tear. So there should not be any controversy over this. The force couples, I leave it to Mansi to decide, but I've already discussed a few. She's going to discuss a couple of more, so I will not snatch her thunder. We'll let us, but these are very important to understand biomechanics and rehab. A little bit about teres minor, which is disregarded, doesn't get its importance. These are two different patients with two different conditions. And you can see what I'm showing you on the MRI is a massively hypertrophied teres minor here. And here is the normal size of the teres minor, which is usually less than half of the infraspinatus. So a patient on the left who came with a rotator cuff tear with a fall history of 3 weeks, it is unlikely that he had a problem 3 weeks back. Because the teres minor is hypertrophied, it means that it has been contributing to external rotation to substitute a weak infraspinatus chronically. It takes years to allow a physiologically small muscle to become double its size to compensate a weak infraspinatus. And I keep maintaining this, that the infra weakness starts first. And that's why it's important to take and tell the patient that this is a chronic problem. It's not a fresh problem. You will take longer to get better on this, as opposed to the patient on the right, who's a fresh tear, genuine acute rotator cuff tear. So let's not be judgmental by saying that I operated both patients and the patient on the left is taking years to get better, whereas the right one got better within 3 months. So this is one of the reasons why patients can improve at different time intervals. It's important to understand that when the force couples are intact, in the absence of a supraspinatus, your therapist can restore function, can restore normalcy to that patient because they have the force couples to work with. But the substitute surgery such as lat dorsal transfer, SCR, partial cuff repairs will not work if the subscap is not strong enough. On the same corollary, if one has a massive anterior superior migration and there's a massive tear, it's unlikely that any of the conditions will work. Neither these transfers, neither SCR nor rehab will work because it's impossible to restore those normalcy now. So what I mean by biomechanically neutral at the end of my talk is that the head of the humerus is centered on that glenoid. If you ask me what does PSRP do, it does very much. It brings the head of humerus back in the center of the glenoid. It's easier said than done. To do that, you have to correct the scapular kinesis. You have to restore the balance between the subscap and infra, which is already imbalanced. The subscap internal rotators are 20% stronger than the external rotators. You restore that ratio. You restore the force couple between supra and infra. You stretch out the tight capsules, and there you go. You've got the answer of how to rehabilitate a patient. How to do this? There's a lot more neuromuscular control rather than strengthening individual muscles. So don't look at this fellow's infra is weak, I will strengthen infra. That is not going to work. It is the neuromuscular control, the timing that the muscles kick in, the sequence that they kick in, and that is where the therapist comes out top and they do a fantastic job. So the main role of PSRP is to get the neuromuscular activated. There's a lot of debate on empty can versus full can, and there's everything in the literature that makes some favor this, some favor that, and we can continue to argue till the cows come home. But what is important is what works in your hand. It's important not to let the impingement occur when they are doing the band strengthening. They don't elevate the shoulder, and the fact that what you're doing is transmitted to the supraspinatus. We are great believers in empty can, helping supraspinatus maximize the recruitment, and you have to take it from me, from our experience. But whatever works in your hand is good enough. Ensure there's no impingement during rehab. So any patient that is elevating the shoulder is bad news. It will create more pain and they will not progress. So that is why during every TheraBand, every exercise band that we use during PSRP, our patients will brace their shoulders behind and then do. That kind of negates the shoulder elevation. That kind of brings the acromion back and prevents the supraspinal nipping against the acromion, which is already on a very loose ground, wet ice situation. That's fine. So finally, on the take home, uh, we are dependent on the physios. It's important they do the right thing. The control is neuromuscular. Some of these patients are neuromuscular artists. They get it done easily. 7th day, they are pain-free. And some of them just can't get it. It has nothing to do with their academic education. We have IT professionals who struggle to get their strength back and do all their exercise incorrectly. So it is, you have to identify those neuromuscular idiots and work on them for a much longer time, as opposed to the artists who will correct the technique, because it's all about muscle memory. A good smart physiotherapist will be able to ingratiate that muscle memory quickly, and that comes with experience. That is not automatic. And do understand that there are heterogeneous issues that impact the shoulder, and it's not just a one muscle problem as such. And those who are interested, the fourth in the series of Jargon Busters will be the MSK shoulder imaging tomorrow, 3 to 5 p.m., again hosted by Ortho TV. Thank you very much. Can I ask Mansi Shah to take over and load her presentation and unmute her mic?
Babhulkar, you missed about subscapularis, to remind you.
Right. Do you want me to talk about it now, or should
I? Meanwhile, Manasi.
Okay. Okay. Thank you, Raghu. Thank you. I'm getting old. You can see that. All
right. Am I on?
Spoils everything.
Yes. Can you start your?
You are audible. Yeah. The subscapularis, as it is with all the other internal rotators, is a very, very strong muscle. And our first PSRP involved treating all the rotator cuff muscles. So because we knew rotator cuff was subscap, infra, and supra, we were treating all of that. But what we later understood, that there is a mismatch between the internal rotator strength and the external rotator strength. So as it is, the internal rotators are 20% stronger. If we rehabilitate both of these muscles, and the infra is very difficult to rehabilitate, we are strengthening the subscap even more, and that is rehabilitating faster, and infra is lagging behind. And that is drawing the head of humerus anteriorly off the center of rotation anteriorly. So all our patients, we ensure we do not address their subscap, and we neglect the subscap in order to give a lift to the infraspinatus. It's like a toe lift to the infraspinatus to bring it to the level of the subscapularis. There are exceptions to this. One of the exceptions I discussed was slap tears, where there is proven subscap fatigue. The other exception to this is patients who have had a subscap tear and we have repaired the subscap, then we ought to treat them in that manner. So those are the few exceptions, such as in reverse shoulder arthroplasty, subscap repairs, and slap tears, that we will actually address a subscapular strengthening. Otherwise, 90% of patients, we do not give them subscap. It has helped us patients achieve their movement function faster.
All right.
Yes, Mansi.
Yeah,
you can take over.
Thank you so much.
Please.
At the onset, I would like to thank the organizers for giving me this wonderful opportunity and to be a part of this webinar. Thank you so much, Shoulder and Elbow Society of India. So now, after a great session that we've had, which was really brainstorming on biomechanics of the shoulder joint, I'm now going to shift focus to what we as therapists can offer and where should we not intervene, or rather, what is the ideal time that the therapist should be a part of the protocol. So when the patient comes to us, the patient is not going to come and tell us that I have this specific dysfunction or I have this specific problem in terms of, just give me a second. Sorry. Yeah, I'm sorry, my screen had gone off over here on my screen. So when the patient comes to us in our clinic, the patient is going to come and tell us, I have this pain and I want you to fix it. Or this is one specific activity of daily living that I'm not able to do and I want to return back to optimal function. Most often than not, patients usually discern loss of function and reach only when pain has arrived. For us, it is a little bit of a challenge in our scenario because most of the times patients expect that, I'm going to go to the physiotherapist, they're going to put me on a couple of modalities and my pain is going to go off. We need to explain the patient that the irony of the entire thing is that unless we kick off the strength of the rotator cuff, pain is not going to resolve completely. Now we've achieved this, we would want to assess the patient and prioritize our treatment goals. The rehabilitation model is often patient outcome centric. It is dependent on several factors like strength gain, which is both at local level and at core muscle strength, stability, mobility, motor control and rhythm, and pain modulation. Generically given, strength training exercises are a continuum of motor control. There are a lot of causative factors which are beyond the scope of a physiotherapist. Could be alterations in anatomy. There would be patients who come to us with structural problems like kyphosis or torticollis, and we have limited role to play in them, or an altered nerve function. Whereas there are quite a few which are within our reach, especially physiological changes like muscle flexibility or strength, or alterations in mechanics. Could be both at static position or during motions. Once we manage to assess the patient and come down to a correct pathomechanics, or rather the altered pathomechanics that we've addressed in these patients, half our battle is won right here. And as Ben Kibler says, about 67 to 100% of our patients who present to us with shoulder symptoms have some form of scapular dyskinesis or have altered scapulohumeral rhythm. At this point of time, it is very important to assess the scapula both in static position and in dynamic motion. Ideally, I would ask my patient first to observe their posture. More often than not, the patient is not knowing that what is faulty and what is ideal. So I take my first session in front of the mirror. I would ask the patient to observe the posture, find out if they have a slightly forward head, is there a rounding in the thoracic spine, is there a pelvic tilt that they have noticed, and try and achieve a more neutral position, a neutral head, a more upright position. More often than not, patient is not usually going to be able to optimize the ideal position in first session itself, but creating an awareness of what is right and what is wrong, that itself is enough to begin with. As Sir had explained, talking about the upper cross syndrome that was explained by Yanda, a lot of times we address these patients in our clinic who are very anxious, and I also counsel them that, when you have been sitting on the computer for a long number of hours, observe your posture, take a break, understand your work ergonomics. Ideally, what is your table height or what is your screen's positioning? Please see to it that your screen is in front, you're not in an angle, your table height, your chair height, all of these are a part of our posture correction program that we go through. So coming back over here, we have inhibited rhomboids and serratus anterior, inhibited neck deep flexors. At the same time, we have tight pectorals and we have tight upper trapezius and levator scapulae. As we know, taut muscles are going to inhibit the lax muscles over here. Talking of the force couples, or rather the powerhouses, I as a physiotherapist would say that if we are able to help you with optimizing the force couples, our job is well done. Over here, as you may see on the screen, the deltoid has a superior translatory force as well as a rotational component, but the superior translatory force of deltoid is way stronger than the rotatory component. At the same time, that is offset by the rotator cuff muscles, infraspinatus, subscapularis, and teres minor. We also have the force couples in the transverse plane, which is the subscapularis and the infraspinatus. We need to achieve an excellent balance between these muscles. Most of the times, as Sir had explained, we need to work on the infraspinatus more than the subscapularis. I'm sorry. A lot of times, there are a lot of adjuncts that we use in the clinic. Sometimes if the patient doesn't have a good kinesthetic awareness of how his posture is, we want to give them a lot of tactile feedback. Sometimes if the patient still fails to understand or is not able to achieve the optimal, before we start the exercises, we could use an adjunct like taping. It could be a kinesthetic tape that we use. Heat packs versus ice packs. We would use a heat pack in patients who are really anxious with taut upper trap or levator scapulae. Ice packs used in cases which are post-operative. They are inflammatory patients. We may use ice packs. Ice packs are very good post-exercise sessions. Lot of times the patient is unable to stabilize their scapula in standing position and has very poor scapular control. In these set of patients, we would put the patient into supine position. Ask them to learn a couple of exercises in this position. Let them understand what their body is trying to do. Let them understand that what is faulty, what is correct, and then put them into an upright position. A lot of times, what I start with is an exercise in sideline position. Ask the patient to go from complete protraction to complete retraction, help them, assist them, give them a lot of kinesthetic awareness of what they are doing. And that is what something tells them about the extremes. And in turn, ask them that this is the neutral that I want you to work on. This neutral position is going to be very helpful to us when we start our exercise sessions at length. A lot of times stimulation is also an adjunct that we use, especially stimulating the supraspinatus and the infraspinatus. Biomechanical machines that are available, we have pocket biofeedback machines that are available. We can use those and train the patient. They give us a beep, whether it is right or wrong, or they give a video screen output and tell the patient what they're doing is right or wrong. So these adjuncts can be used as well. Going to scapular stabilization exercises. So these are a set of exercises that we start with. The first over here is the lawnmower exercises. This is the low row, robbery, or the inferior glide. My main point over here would be, what is my ideal starting position? If the patient is in a faulty posture to begin with, whatever I try, my outcome is not going to be achieved. So we have to see to it that the patient does not do trick movements and the exercises that he is going to do is correct. The most common trick movements that patients do are flaring the chest or arching their back. We need to be careful that they do not elevate the girdle. For the beginning, we always try to put the patient in front of the mirror, ask them to look at themselves so that they can have a feedback of what is right and what is wrong. We also tell them not to tighten their neck or do not hold your breath. The only key point over here is, remember, it is back and down. They need to understand that the scapula that they are going to brace behind has to go down in back and down position as if they're going to put it in their back pockets. So this is the standing bracing exercise. We eventually put the patient into prone. Along with this, they need to first do the standing brace exercise and then eventually lift the arm. We are adding leverage over here of the body weight. Shift to advanced exercises like the YTWL. At this point of time, I would like to say we do not endorse free weights. And as you see over here, we've put a cross on free weights to increase the joint shear. Along with scapular exercises, it is important that we start training the core muscles. We've already talked about it earlier in Sir's lecture, and even Dr. Ram had mentioned that it is very important that we start working on the core. More often than not, we're always asked this question of why should we train the core muscles? So we have four main core muscles in our body: the diaphragm superiorly, pelvic floor muscle inferiorly, transversus abdominis interiorly, and multifidus posteriorly. And as Punjabi and White had mentioned, that our spinal stability is dependent upon passive subsystem, which is the osseous and the ligaments, the active subsystem, which is our muscles, and our neural control. So all of these factors come in play into spinal stability. So coming back to my answer of why should I train my core? Our body has a feed forward mechanism that it works on. As we can see over here, our body has an anticipatory posture control, which is created when our proximal stabilizers start to fire. Only after the stabilization step is done, the preparatory step is done, do our distal movers start functioning. And hence, a lot of EMG studies have been done on this, and they've also seen the firing pattern being altered. Whenever we have an injury, it could be our shoulder or our knee. Whenever we have an injury, the firing pattern or the sequence in which the muscles fire is also altered. Hence, it is very imperative and it's very important that we put emphasis to our patients that I know it is not related to your shoulder directly, but believe us, there's a science and you need to perform these exercises. So starting with the basics over here again, we aim at local segmental control and then eventually shift to open segmental control, shift